Hello, my name is Anita Somvalreo. I'm a student in Nursing 7070. This is a croup case study with evidence-based practice in management. I chose this case for a 6-year-old guy, Caucasian male, because he came with ideal, perfect um, symptoms of barking cough, stridor, um, a sore throat. His chief complaint was, I have a cough and my chest bothers me. History of present illness. He's a 6-year-old male with no prior medical history. His throat was hurting when he was coughing. He has nasal congestion, barky cough at night, chest discomfort, and slight wheezing. He has little loss of appetite, and he hasn't slept in one day. All these symptoms started yesterday, like one day ago. So I've done PQRST for the pain. He denies fever, chills, nausea, vomiting, diarrhea, constipation, and headache. No medical history, no past surgical history. As per mother, family history, both parents are living. He lives with his parents. Father has cholesterol and hypertension, and mother has asthma. Subjective, he's alert, awake, oriented, lives with his parents. His parents are in a good community, in marriage relationships, so the environment is really good at home. He has no pets. Parents are non-smokers, and they're big on safety. They don't own gun, and all his other daily functions are normal. This is the milestone growth development for a 6-year-old. He's on track with everything. He's excited about getting his lower incisors in first molars. When he was having pain, mom gave him medication, Tylenol 10 ml. Every 8 hours is needed. He doesn't have any allergies, no food allergies, environmental allergies. His last physical was October. He's good. There was no issues. And his immunization is up to date. In subjective, mom denies everything. He just has slight sore throat and nasal secretions, and that's basically it. Otherwise, he doesn't. He was having no slight pain when he coughs, but nothing constant. On examination, his vital signs were 100/64, which was normal. Heart rate 75, respiration 22, temperature 98.5. He didn't have any fever. He was afebrile. Oxygenation was a little bit 97, but it was over 95. So, and his BMI is good. Everything is good in general. Sclera, eyes, ears were normal. No tenderness anywhere. Throat, neck, nothing was noted. Yeah, except for in respiratory, he was clear on auscultation. Even though you felt there was wheezing, he had a barking cough you could hear, and you could hear stridor like when he moved around a little bit, but no retractions, no grunting, nothing of that sort. Everything else was normal. Assessment. The impression that we got was a croup. You can have that barking cough. Croup is an upper respiratory infection. It is also known as acute laryngotracheitis, where it affects larynx and trachea, or laryngotracheobronchitis, where it also includes bronchi. So both names go with it. In adults, it's known as laryngitis, which was very interesting. Croup is a common childhood illness. It causes vocal cords to swell up, and that's why you get the stridor and the barky cough. That sounds like a seal. It is usually, you'll see different places, they'll say 0 to 3, but most of the places I read, it said it goes up to 6 years of age. It can be in older children. In the practice that I did see, there was a kid, there were two patients actually. There were one was 8-year-old and one was 10-year-old. And they both had the same, you know, um, treatment and everything, and they were fine. It's so basically he said that it started with nasal stuffiness, runny nose. Mom thought it was you know, flu, but apparently when he started barking, that's when she brought him in. Um, So when in severe, so you have mild cases, and then in most severe cases there can be distress in breathing. When that happens, it's like a really high pitched sound. You'll hear a creaking sound, like a whistling sound. That is stridor. He did have a slight stridor, but it was not like you would see in a severe case. He wheezing is different, because wheezing is when you have difficulty when he's breathing the air out of the lungs. And usually stridor is inspiratory, and croup is usually worst at night. So the four main things to see is nasal congestion, barky cough, hoarseness, stridor, the hallmark signs. Sore throat, fever may be present or not, not necessarily. Majority of the symptoms, they are mild and they last 3 to 7 days, with the worst symptoms being on the third and the fourth day, and then they get better. And if anything has to get worse, it'll be worse between 12 to 48 hours from the time the symptom starts. There's also a spasmodic croup. Usually this comes at night and is thought to be due to allergy or reflux from the stomach. There's a diagram for people to see. Causes of croup usually are parainfluenza virus, but there's also RSV, influenza A and B, and it can also be caused by adenoenterovirus. Spread is usually droplet and contact when they touch any surfaces or when they sneeze and cough. You can, um, you know, it goes in the air. The croup is usually classified into three different kind: mild, moderate, and severe, and their management is also on that. So this is the classification of croup. The severity of the croup is usually based on the Wesley Croup severity score. This is the most places is used Wesley. It's very common, and it ranges from 0 to 17 points. And it depends on the five factors that you can see on the side: level of consciousness, cyanosis, stridor, air entry, and retractions. So the presentation depends. So mild is usually less than 2 score, barky cough, stridor, or no stridor at rest. There can be some stridor activity, but he doesn't have any problem breathing. Same thing with moderate. You have stridor, tachypnea. They have problem breathing, anxiety, agitation, restlessness. In severe, there is stridor at rest. They severe respiratory problems, breathing issues, fatigue. They have to put themselves in a tripod position. There's decreased LOC, inability to talk, lethargy, cyanosis, and their retractions. Mm. Then there is impending respiratory failure. Like if it gets really, really bad, this has to be like hospitalized. In this, the stridor may be present or decreased. Like the severe problem, like they have to really work at their breathing. There's poor respiratory effort. There's hypoxemia. You need oxygen at this point, and they could be listless. There's another classification. I just found it on the internet. I thought this was interesting to look at. Then there's one recurrent atypical. This is not a diagnosis. This is just the way they present. So if a child has recurrent is like more than two croup illnesses per year, it is recurrent. And atypical is when they fall outside the age range. Some say 6 months to 3 years. It could be up to 6 years. So after 6 years, if they have croup and they're getting many, then there is other problems as well associated with it. But that is known as atypical. So when that happens, it's very important that you refer these kids to gastroenterologists, otolaryngologists, pulmonologists, so they can further investigate. Diagnosis of croup is like this is general, so it's usually done with a good physical exam. History is required. We need to know what the patient, if he had like a viral disease recently, does he have any breathing problems, if they have asthma or anything, are they in so we have to give them a good exam and listen to their lungs, listen to their breathing, to see if they have any stridor. We can see that, we have to examine the larynx if it's swollen, if they are in any kind of respiratory distress. Also, to make a note, x-rays are not taken for mild croup. They can, if need be, for severe croup, but no, usually labs and x-rays are not required. So if they in severe x-ray, you will see, like in severe croup, you'll see steeple shape narrowing of the trachea. This is the steeple sign that you can see the narrowing of the trachea that is in the AP view of the neck. Um, and no labs are required. Evidence-based plan and clinical guidance. I researched a lot, and management of croup is based on severity of illness. Treatment of the patient is very important. Usually, everybody suggested, like, I researched American Academy of Family Physicians, PEDS place, Up to Date. These are the main places that. And then, of course, I also researched NHS, British Medical Journal, Australian Journal, and they all basically had the same um, treatment plan and management that was for glucose steroids, epinephrine, and then if it was severe, there's a mixture of heliox, where it is mixed with helium and oxygen. So the density is less, so it helps in breathing. So corticosteroids primarily are dexamethasone and prednisone and dexamethasone is the first line of choice because it decreases swelling. And but out of the two glucocorticosteroids, dexamethasone is suggested more. Then you have, I've written the doses for them. And then you have epinephrine. Epinephrine is a vasoconstrictor, so it decreases edema. So the fluids go less, and then it decreases, in the area to the larynx. So since there's not fluids going there, so the edema becomes less. And it works very well with corticosteroids because epinephrine is short acting, corticosteroids are long acting, so they both blend well together. They can be given in the form of nebulizer for the patients, those who can't swallow, and they have done studies, and they say they definitely reduce the score. So my patient mostly had mild croup. So children with the croup, they recover between 3 to 7 days. Most children get effective treatment in the office. I've written here, single dose of oral dexamethasone was given, and they can either get dexamethasone or prednisone, but dexamethasone is preferred. And this shortens the duration of the future visits and health costs. It usually starts working in few hours. Um, and since the disease only lasts like maybe 3 or 4 days, the dexamethasone actually works for 72 hours. So it helps a lot. Um, for more moderate and severe croup, you can, it's the same thing. You have to give dexamethasone, epinephrine, racemic epinephrine, which is a little shorter acting. Then L-epinephrine is a little longer acting. It acts for 2 hours. And then I've written the doses. But one thing very important is to watch for rebound effect. So they usually say to watch for 4 hours. This is some algorithms I brought down. Dosages, these are the dosages I've written that usually are given. These are from evidence-based practice. How do you treat croup at home? That's a very important thing for mild croup. It can be treated at home easily, especially if they've seen pediatric office. So you have to make sure they have humidifier, steam. They can sit in the steam. Cool night air helps them breathe. You have to make sure the child is calm, no anxiety, and this will help them. So working diagnosis again for the patient after seeing all this was croup and it was mild. After thorough physical exam, barky cough was hard to miss, and they were all signs and symptoms of croup. Runny nose, inspiratory stridor, and we didn't do any labs. Chest X-ray could have been done. It's not recommended, only to please the mom. The differential diagnosis I chose were dependent on the age group. Initially, I was thinking of bronchiolitis, but that is only till 2 years of age, and the patient is 6 years of age. So I went with the following three. Epiglottitis, that is a medical emergency where the epiglottis swells up and blocks the airway, and you can read all about that. It occurs in smaller children, so it's harder because even if there's little swelling, it blocks it. So you have to have they go in respiratory distress very fast. The next diagnosis was retropharyngeal abscess. This happens due to trauma or infection, tooth pain, kids have a lot of cavities. It can block the pharyngeal space and block the airway. The third one is bacterial tracheitis. This is high fever. This can be life-threatening, high fever, stridor. So this you have to monitor, and they have to be hospitalized for that because they need IV antibiotics and IV fluids. This is another table. Prevention, since you have to treat this like a viral infection, hand washing, alcohol sanitizers, and you have to keep the kids at home till if they have fever till the fever goes away, or at least 3 days, 4 days after the symptoms appear. So the patient have to be very careful. Warning signs, these are very important. This is in mild, they're okay. Like if they can get worse like really really fast, so you have to there are two kinds. You have to do either call the doctor, so if the symptoms don't go away and the stridor is present, or they're having mild problem in breathing, even the nebulizer is not working, you should call the doctor's office. But if they cannot breathe, they have trouble swallowing, have retractions, blue tint skin, lips, and cannot cough, cannot stop coughing, and they need oxygen, they need hospitalization, don't drive your kid to the hospital. Call 911 because they can manage the kid on the way. Plan. So the plan is for my patient was, since he had mild croup, we just gave him a prescription of Tylenol to give him 15 ml every 6 to 8 hours, and not to exceed 5 doses. We gave him a dexamethasone 10 milligram PO in the office, to cover for his 3 to 4 days. They also told the mom that give him cool mist, run hot showers, steamy environment will help. Have him take water so he stays hydrated, provide humidity, will help him breathe. He can sit up, and most importantly, to stay up with him at night because the croup is worst at night. Education for the mom, it was given on liquid hydration, prevention, precautions, how to prevent the spread, home remedies, as we talked earlier, and the warning signs. And we also told the mom that to keep him in a comfortable position and encourage rest and calm. Referrals, there were no referrals at this point, because when a kid went home, mom called back and said he was fine. Follow up just for this to be safe side. We told them to come back in a week, or if he gets worse, to call in 48 to 72 hours, and she can call for anything. This is anticipatory guidance. Rationale was, for the treatment was because we had chosen um, uh, researched everywhere, and everyone says dexamethasone is to be given first. That's a drug of choice, and the dosages are the same. So we followed the dosages and gave them according to the recommendations, and the patient felt better. And he was fine in 1 week when he called back, and mom was very happy. The points we have addressed. This is treatment goals and projected outcomes. This is, I talk about the good treatment and the bad outcomes, like good outcomes and the bad outcomes. The treatment goal is mainly, to get the patient breathing. This is evidence-based clinical research. Again, everything was according to the guidelines published. Confirmed diagnosis, there was no modification because the patient was fine. He just got 1 dose of dexamethasone. Cost implications, the dexamethasone saved from further visits, hospitalizations, avoiding intubation. So a lot of healthcare costs were prevented. Summarize the significance. The nurse has the APN plays a very critical role. And this just shows to go that you have to have evidence-based practice. You have to be current with the latest research, continuity of care. You have to keep up with research, interact with other professionals, and learn how to deal with families. You have to address parents' concerns, learn to recognize symptoms, and safety. And APNs have to do their best for their patients. These are the questions and references, and thank you.